Hi, I'm Dr. Steve Ratcliff. Welcome to a team training. TMJ isn't a disease. We all have patients in our practice who come in and they hold their hand to their face and they say, I've got TMJ. What does that mean? Well, in this team training, we're going to give you a chance to understand a little bit more about the temporomandibular joint and about the different disease or dysfunctions that can happen in that joint that can cause patients to come in with the statement, I've got TMJ. So we'll define what the temporomandibular joint is. We will talk about what is TM dysfunction, temporomandibular dysfunction. We'll talk about the difference between joint pain and muscle pain, and then we'll talk about some of the treatment. The temporomandibular joint is a joint that connects the jaw to the skull, really. The connection occurs because muscles are attached to both the lower jaw and to the skull. Inside of the joint are several components that, if affected, can cause dysfunction or pain. One of the most important parts is the condyle. It's the upper part of the lower jaw. If you think about a joint having a ball and a socket, which is really oversimplifying this joint, but if you think about it that way, the condyle is the ball. The fossa, or the receptacle, is where that ball sits. In front of the fossa is a part of the skull called the eminence. Between the condyle and the eminence is a cartilaginous disc. That disc has what's called synovial fluid that is excreted by little villi around the disc that keeps it lubricated. So when we open and close our jaws, the condyle and the disc move at the same time in a healthy joint. One of the main muscles that causes the lower jaw to be able to move forward is called the lateral pterygoid muscle. Part of the muscle attaches to the condyle, and a little bit of the muscle attaches to the disc. In normal function, that muscle doesn't have any discomfort at all. Behind the condyle and the disc is a bunch of tissue that has connective tissue, nerves, blood vessels, and some ligaments that we call the retrodiscal tissue. That can be the most common source of pain inside of the jaw joint. If that tissue gets stretched or torn, because it is so highly innervated, it can be pretty uncomfortable. Now, this is what a normal joint looks like. Kind of looks like. Actually, this is a cadaver that's been cut in half, so it's not a normal joint. If you notice, as the condyle moves down the eminence, the disc stays with the condyle. You can see the muscle in front of the condyle, so when that muscle contracts, that's what brings the condyle forward. Behind the condyle is the retrodiscal tissue. That's the tissue that, when damaged, can become inflamed. Now, sometimes your patients will come in and they'll complain of noises in their jaw joint. This is one example of what causes the noise. As this patient opens, that disc pops back on the condyle. As the patient closes, it pops off. The disc in this case has been damaged. It's torn, and it's started to move away from the condyle. So when the patient opens, the disc is recaptured, if you will. It slides back on top of the condyle. This can be caused by external trauma, such as a blow or hitting something hard. A very common cause of injuries to the jaw joints occur in children when they fall down and hit their chin. So if you have patients that have a history of clicking or popping or other noises, ask them if they've ever had a chin injury. Did they fall over the front of a bicycle? Did they trip going up a flight of stairs and land? Sometimes you'll see a scar underneath their chin. Those are not uncommon findings in people that complain of joint noises. The other thing that can sometimes cause these tears or changes inside of the joint, tears to the disc, are what are called microtraumas. And one cause of microtrauma is nighttime or daytime clenching or grinding. more so heavy grinding, because it can cause damage to that disc, and it can eventually tear and start to move off of the condyle. Just because that disc has been damaged doesn't mean that the patient has dysfunction or that they'll have pain. Many people function very normally with a click. As a matter of fact, it's been estimated that between 35 and 45% of all of our patients have some sort of damage in their jaw joint and may have a noise of some sort. But if that damage continues, and sometimes it does, then it can become a source of pain, or it can become a source of other dysfunctions, meaning that the jaw doesn't open as normally as a patient would like it to. They have some deviation when they open or close, or sometimes they'll even have pain upon movement. The picture on the screen shows a disc that is slipped in front of the condyle. Now, sometimes when those discs move completely off of the condyle, it can keep the jaw from opening or closing all the way, and a patient will complain that their jaw sometimes locks shut or open. One of the things that I as a dentist need to determine if a patient comes in with some of these symptoms is that joint stable enough so that I can do treatment. If a patient has an unstable jaw joint, and by unstable I mean that they have an inability to move normally, or that they have pain upon movement or upon squeezing their teeth together, I shouldn't be doing anything to the tops of the teeth until those issues are resolved. But if a patient has joint noises, a click or a pop, I can be pretty sure that that's a stable joint, and I can treat that patient's teeth if the noise has not changed for 2 years or more, if there's no pain inside of the jaw joint, and if the patient can freely move their lower jaw in all directions. That joint we can stabilize. Really, the most common cause of TMJ that patients come in with are really sore muscles. Muscles get sore when they're overworked, and clenching or bruxing can cause that overwork and can cause the soreness. The most common muscles to get sore are the muscles of positioning or opening, which are the lateral pterygoid muscles, and some of the muscles underneath the jaw. The big muscles, the elevators, which close the jaw and to a certain degree help it move from side to side, are the big masseter muscle and the big temporalis muscle. The way we determine which muscle it is simply by palpating the muscles and asking the patient if it feels sore, tender, or they feel tension in that area. And then we may record how severe the discomfort is on a 1 to 10 scale. If a patient has sore muscles, I really don't want to treat their teeth until I resolve the cause of the soreness, or at least understand it. The reason is, when muscles are sore, it's just like when you go to the gym and you're lifting weights and you haven't done it for a while, and you wake up the next day and you feel a little bit of something going on there. The day after, it gets really sore, and then gradually that soreness goes away. That soreness is caused by overuse of the muscle, meaning you've used it in ways that you're not used to using it, and as a result of that overuse, toxins build up. Lactic acid builds up in the muscles, and until those toxins dissipate, the muscles will be sore. If we don't stop the cause of the sore muscles, and in the case of many patients, it's what they're doing with their teeth. They're clenching their jaws, or they're grinding at night, or they have some habit. If that doesn't stop, the discomfort doesn't go away. If I change the position of the teeth, sometimes that changes the way the muscles work. And I may restore a tooth, the muscles shift just a little bit or start to work differently, and now all of a sudden the patient tells me that their bite is off. So I want to resolve that soreness before I take care of the teeth. This is a patient that I've seen who clenches at night. She's got very well-developed masseter muscles, and if she squeezes together and you put your hand on top of her cheeks, you can feel how bulging those muscles are. If we look at her teeth inside of her mouth, notice that things are breaking. She's got wear patterns. She's got cracks in her teeth. Those are all signs of what we call habits, parafunctional habits, that can lead to temporomandibular dysfunction. So when we see these things, how do we treat them? Well, this can be a really complicated subject, but usually your doctor may pick one of 3 different types of treatments to really understand what's happening in your patient's mouth. That may be the only treatment that's needed. Sometimes more complex treatments are needed. That's beyond the scope of what we're trying to do in this short team meeting. This is what's called an anterior deprogrammer. It's simply a piece of plastic that's held in place with some bite registration paste. It keeps the back teeth from touching. By doing that, the muscles begin to relax a little bit, because what happens when people clench is that all the positioning muscles are firing. So when we put that anterior deprogrammer in, it takes away all of the influences of the back teeth, and the lateral pterygoid muscles and some of the other positioning and closing muscles begin to relax. And after a period of time, the jaw goes into the correct position and the muscle tenderness goes away. We may use an anterior deprogrammer as a screening device. Most of the time when I use one, I'll use it in my office while the patient is there. I'll have them wear it for 15 to 30 minutes and then check and see if the muscles still feel sore. If they don't feel sore, I've got a really good idea of what's happening, and it's probably because of what they're doing with their teeth, and we can create a device like this, which is an anterior bite plane. They may be able to wear this at night. It may keep their back teeth from touching, and it may help alleviate some of the muscle soreness that they complain about. It's simply a device that fits over all of the teeth and has a very flat ramp in front that allows the lower jaw to move wherever it wants to go without the interference of back teeth. It works like an anterior deprogrammer, but it's slightly different because this device covers all of the teeth. I still don't want my patients to wear this more than 8 hours at night, because if they do wear it longer than that, some of the lower teeth can begin to super erupt a little bit and create some bite problems. In more complicated cases, where there may be something going on inside of the jaw joint, there may be some pain in that retrodiscal tissue, or it may be muscle tenderness that just doesn't respond to the other 2 appliances, I'll use what we call a full coverage appliance. They come in many different configurations: upper jaw, lower jaw, wide, thick, thin, fat. The one on the screen is one that I like to use, and it allows the patient to move in all directions very smoothly, but it also has equal intensity stops on the back teeth, so that when the patient closes gently, all of the back teeth touch at the same time. So, TMJ isn't a disease, it's a joint, it's a structure. TMD is dysfunction. It includes damage and disease and muscle issues. Most TMD is easily managed with bite appliances. In some cases, however, it's much more complex, and your doctor may choose to refer your patient to somebody who only treats complex temporomandibular dysfunction. We've included a discussion guide for you with this team meeting, so I'm sure you've probably already printed it out, and you can follow along with the questions and create some dialogue in your own office about how you're going to work with these patients. Thanks for being with me.